After such a beautiful demonstration, now we'll move on to IR table-viva. I hope you're able to see my screen. Are you able to see my screen?
Yes, ma'am, you are visible.
Okay, my screen is visible.
Yes, ma'am, it is visible.
Okay. So, as you've already been told, the purpose of Viva is to correctly identify all the instruments, and also you have to know a little bit about the uses, the indications, the method of use, and if required, some complications. And also you have to remember them and reproduce them within the time limit of the Viva. So for that, it's important that you've already seen these instruments and also you've understood how they are used so that you can recall it in time. So I'll start with a brief introduction to intervention radiology, which includes doing minimally invasive procedures under imaging guidance, which can be either CT or ultrasound, and most commonly it's under fluoroscopy. Then interventions are either vascular interventions, wherein all the procedures are done within the vascular compartment, which may be the arteries or the veins. So the route of entries are either transarterial or transvenous or percutaneous. And then we have non-vascular interventions, which are procedures performed outside the vascular compartment. And these includes FNAs, biopsies, drainages, and ablations. So to start with, first of all, we have to know the most common machine which is used for doing the II procedures, which is a DSA machine. It can be a uniplanar machine or a biplanar machine. By a biplanar machine, we mean that there are two C-arms, and each C-arm has an image intensifier on one side and the X-ray source on the other side. So biplane machine usually used for neurological procedures, and a single plane machine is used for peripheral procedures. Then we have the radiation protection devices, which I'm sure will be discussed in detail later. But basically, these include the lead gowns, thyroid shields, the radioprotective goggles, and lead caps, which are very essential. Then any procedure starts with preparing the patient. So you all have to know that the disinfectant or the sterilizing agent which we use is povidone iodine solution, which is yellow or brownish in color. And the area where the access has to be made is cleaned in a circular motion from inside out. For vascular procedures, usually the access is through the common femoral vein or the radial access. So if it's the common femoral vein, then the area around the site of entry has to be cleaned. For this, we clean area from the level of umbilicus till the mid-thigh. And for a radial access, the area from mid-palm to mid-forearm is cleaned. And then thereafter, local anesthetic agent is given, which is lidocaine without adrenaline. It's without adrenaline because we don't want the vessels to undergo spasm. And that's why adrenaline is not used. So once that is done, we begin with the first step of all interventions, which is obtaining a vascular access. So for that, we have to be very well versed with all our equipment, and some international measurement techniques we have to know. The tubes and catheters are measured in French, and we have to know that 3 French equals 1 millimeter. So this basic knowledge of conversion of French into millimeter has to be known. Others you can skip, but this you should know. Then wires are measured in inches and the needles are measured in gauge. So the first step is vascular access, which is mostly intraarterial or maybe venous. The most common route is the common femoral artery route. And so the vascular access equipment consists of a puncture needle, a small guide wire, and a vascular entry sheath. So first and foremost is a puncture needle. So puncture needles are usually made of stainless steel, And these can be either single part needles, which means it's a hollow needle, which has only one component, which is the needle, which is connected to a hub. They usually have a beveled edge on the other end, and they are most commonly used for a single wall puncture. That is when only the anterior wall of the artery is punctured. Then we have bipart or two-part needles, which means that there's an inner stellate and an outer sheath or outer shaft of the needle, and inside this we have a stillage which does the cutting. And these types of needles are most commonly used either for drainage procedures like the Chiba needle or the spinal needle, or for vascular access if we are doing a double walled puncture. In a double walled puncture, the needle is taken through and through the artery, and then the inner stylet is removed and the needle is pulled back. So once this needle now enters the lumen of the vessel, we'll see a gush of blood from the other end. So that's when we know that we are in the arterial lumen. And also we have sheath needles, which have an inner metallic component and an outer plastic cannula. Just like a cannula, we have sheath needles, which can be used for radial puncture. So the needle, as I said, is measured in gauge, and gauge is the inner, is usually the outer diameter of the needle. And inner diameter of the needle is slightly less than that of the outer diameter. Usually an 18 gauge needle is used, which can accommodate a 038. This is in inches, and this is the length of this is the diameter of the wire which can pass through the needle. So an 18 gauge needle can accommodate a 038 or a 035 wire. And if it's a pediatric patient, we use a thinner or a smaller needle. And so the wire that goes in is thinner. So it's 018-inch wire. So this is a small video which shows how a vascular access is made. So after cleaning and draping the part, we usually give a local anesthetic injection on the skin, and we make sure that it doesn't go into the artery. So once the area is anesthetized, we select that segment of artery which needs to be punctured. It's the common femoral artery below the inguinal ligament and above the bifurcation. It's usually 3 centimeters below the inguinal ligament and 3 centimeters medial to the midline. So with the help of a 18 gauge needle, a puncture into the artery is made. This needle is usually inserted at an angle of 45 degree to the vertical, and the area selected is area 3 centimeter below the inguinal ligament, 3 centimeter medial to the midline. So with an angle of 30 to 45 degrees, this puncture is made, and once it is inside the vascular lumen, you will see a gush of blood which is coming out from the proximal end of the needle. The end which is towards us is proximal, and this is the distal end. So through this, we insert the guide wire, which is now inside the vessel lumen, and the needle is removed. So now only the introducing guide wire is inside the vessel. Now this guide wire is slightly straightened, and over it, the vascular sheath and dilator assembly is inserted inside. The dilator and the guide wire are both removed, and the sheath remains in situ. This has a hemostatic valve, which we'll just discuss. And through this, multiple catheters can now be passed. So what you have to remember while puncturing is that puncture is always done over the bone, because when you remove the sheath, you have to compress the puncture site. So compression is effective only when it's done over the bone. You can compress against a hard surface. That's why when we select the site, we usually look at the femoral head, and we puncture in the inferomedial aspect of the femoral head. If we divide it into 4 parts, the site in the artery should be somewhere over the inferomedial aspect of the femoral head. So after the needle is inserted, we then have the guide wire. So I'll quickly show you how the guide wire looks like. Am I visible now? So this is a J-shaped guide wire. The distal end is J-shaped. It's soft and atraumatic, and it's small in size because we only need to introduce it in the vessel of access. It comes with an introducer, and this introducer straightens the tip of the wire so that it can be inserted in the needle hub. And what are the advantages of this J shape? The advantage is that the tip becomes atraumatic. And so it doesn't injure the vessel wall. And the other thing is that this J wire prevents hooking of the other small side branches of the vessel. So we can just take it straight inside our main vessel. So that is how it looks like when it is straightened. I think this is not moving. Are you able to see my screen?
Yes, ma'am, screen is visible.
Okay. So next we have the vascular sheath. The vascular sheath again consists of an inner dilator. This is the inner dilator which snugly fits into the sheath. Then it has a shaft, a hub which has a hemostatic valve, and a side tubing which is connected to a three-way for infusion into the sheath, infusion of saline or any heparin inside the sheath. So this sheath is used for vascular access. The hemostatic valve on the other end does not let blood come out. Once it is in place, the dilator is out, and this is used for exchanging different catheters during the procedure and also to avoid injury to the vessel wall. Now, can we do a vascular procedure without having a sheath in situ? The answer is yes, we can. But in that case, we'll not be able to change multiple catheters and there's more risk of injury to the vessel wall. So that's why a sheath is important. Now, these sheaths come in different sizes. So the length of the sheath is different and also the diameter of the sheath is different. What we need to know about the diameter is that if we say it's a 6 French sheath, it's usually the inner diameter of the sheath. Most commonly used for diagnostic procedures are 6 and 5 French. So 6 French sheath is green in color, 5 French is purple, and so different sheaths have different color codings. If I say it's a 6 French sheath, it's the inner diameter, and that means that the catheter which it can accommodate or a catheter which can pass through it is a 6 French catheter or smaller. And length of the sheath, usually femoral sheaths are longer. Femoral sheaths are usually 11 to 11.5 centimeters, and radial access sheaths are usually 7 to 7.5 centimeters. I'll quickly show you the different sheaths. So this is a radial access sheath. It's smaller in size and it's more tapered. This is a 6 French radial access sheath and this is a 6 French femoral access sheath. This is longer as compared to the radial sheath. So, okay, again, quickly, this is how a puncture is done. If it's not ultrasound guided, we palpate the inguinal ligament by palpating the medial tubercle as well as the anterior superior iliac spine. We go 3 centimeters medial, 3 centimeters inferior, and then check that we are in the inferior-medial aspect of the femoral head by placing any radio-opaque instrument over it. So we are here. So that's where we can puncture. And then these are the steps of puncture wherein a needle is put, there's gush of blood coming out. Then through the needle, a guide wire is pulled, is taken inside. Then over the guide wire, a sheath with the dilator assembly is put. That's the hemostatic valve. And through this valve, various catheters can be introduced. So once we are inside, we can do various procedures, any procedure that we want. Basically, we are no better than plumbers. So we are either repairing leaks, that is, we are closing a vessel which is overflowing, or we are opening up a vessel which is blocked. So then the second step after gaining a vascular access is reaching the site of interest. So for that, we have instruments which are catheters and guide wires. So what are catheters? Catheters are basically hollow tubes of metal. They are hollow tubes of plastic. As you can see here, they are made of plastic, which is usually polyethylene or polyurethane. And most of the catheters have a very thin metal braiding within their wall. So whenever we talk of catheters or these hollow tubes, They have a proximal end, which is in our hands, and it is connected to a hub. And then they have a distal end, and in between the two is the shaft of the catheter. So this is the basic construct of a catheter. Then the difference between the proximal and the distal end is that the distal end, which goes in the vessel, is soft and is atraumatic. So this is soft and more foldable, more malleable, whereas the proximal end of the shaft is stiffer. So these catheters now, based on their usage or based on their construct, they can be either selective catheters when their tips have a particular shape and they're used to hook arteries, or they can be non-selective catheters, guiding catheters, and microcatheters. So for catheters, we have to know their diameters and their length. Length of catheters, we have to know because smaller catheters are used for cannulating more proximal vessels, and longer catheters are needed when we need to go more distally into the vasculature. So now when we talk, the most commonly used catheters are selective catheters, and these catheters are used to hook a particular vessel. So their distal end has different shapes. So they can either be straight catheters or they can have a small curve, a single curve like this. So then they are called simple catheters. And if they have more than one curve, they are complex catheters. The curve which is distal most is the primary curve, and the curve proximal to it is the secondary curve. So this is a double curved catheter and this is a single curved catheter. So based on the shape of their curves, they have different names and they are used to hook different vessels. Also in catheters which have a secondary curve, if the direction of the primary and the secondary curve is same, they are known as forward facing catheter. However, if the direction of the primary curve and the secondary curve is different, they are called reverse facing catheters. So reverse facing catheters are usually used to hook vessels which are originating in a direction opposite to the direction of the main artery. So if we are going from the femoral artery, the origin of celiac artery is oriented downwards. So it is not in the direction of where you're going. So in these cases, reverse facing catheters will be helpful. However, if you're trying to hook the left vertebral artery and you're going from the femoral route, so that artery is in line with the direction where you are going. So then a simple catheter is going to be good enough. So this is the headhunter catheter. These shapes you have to remember because these names are very commonly asked in Viva, and also you are asked that where they're used. So headhunter catheter is a complex catheter or a double curve forward facing catheter and is usually used in cannulating head and neck vessels. Then this is a cobra catheter, again a double curve catheter and forward facing. It's the secondary curve is C-shaped, and this is used most commonly in hooking the bronchial arteries for bronchial artery embolization, and sometimes also for hooking the visceral arteries like the SMA or the celiac. Then this catheter is the renal double curve catheter. This is most commonly used for hooking the renal arteries when they are originating at a slightly acute angle, which is opposite to the direction of where we are going. So that's the renal double curve. So this is the cobra catheter, the headhunter catheter, and the renal double curve catheter. After that, this is a multi-purpose catheter, which is a single curve catheter and has a very small slight curve, almost a 45-degree curve. And it is used for hooking vessels which are along the flow of your main vessel. And it is used for in multiple places. Like it can be used in PTBDs if you want to use a catheter, or for various other reasons. This is a Simmons or a sidewinder catheter. So this is a reverse curve catheter, and the uses of this catheter are usually in hooking visceral arteries in angiography, in doing spinal angiograms, or when we have a difficult arch anatomy, like a bovine arch or a type 2 and type 3 arch, when the vessels are originating at an acute angle. Then depending on the diameter of the secondary curve, it is of three types: Simmons type 1, Sim 2, and Sim 3. The size of the secondary curve, the diameter keeps on increasing as the Simmons number increases. And also we have to know that these reverse curve catheters are called reverse for a reason. So that when the vessel is hooked, the origin of the vessel is hooked. Now, if you push the catheter forward, the tip is going to move backwards. However, if you push it backwards, the tip is going to move inwards. That's why they move in a reverse direction. When you introduce them, you cannot introduce them like this. They are stretched out, their curve is opened, and they're introduced over a wire. Then this formation of this curve has to take place inside the body. It is done either at the level of aortic bifurcation or in the arch over the left subclavian artery. Left subclavian artery approach is safer, and it is safer to reform the curve of this catheter here, where it is taken like this over the wire. The wire is removed. This is stuck in the left subclavian artery. It is rotated and a curve is formed. Once this is formed, it can be rotated in this manner, and it can be used to hook difficult origin of the arch vessels like this. Now, when you're going to remove this catheter, you're not just going to pull it back. It is always removed over the wire. So you're going to take the wire inside, take it outside the catheter. This will open up the curve of the catheter, and then the entire assembly is going to be pulled out. So this is another reverse curve catheter, which is the Roberts uterine catheter. It is no longer in use, but when it was in use, it was used for uterine artery embolization. It was used for cannulating the uterine artery in the contralateral and ipsilateral approach when a femoral arterial approach was used. So this catheter is a special type of catheter. So one is on the basis of their construct and their use. The catheters could be either diagnostic catheters, and also then on the basis of holes. They can either have a single hole at the end, or they can have multiple side holes. So all the catheters which we have seen till now are single end hole catheters. Pigtail catheter is a catheter which has multiple side holes as well as an end hole. So the use of this pigtail diagnostic catheter is that it is used in flush aortograms. So this is used whenever we need a high volume and high rate of injection inside a catheter. So because of multiple side holes, the contrast is going to get evenly distributed, and we are going to get a better angiogram. The distribution of contrast in artery is going to be better, and we can use high injection rates. And also the opacification of side branches is going to be better. So all the catheters at their hub, this is the hub of the catheter. They have the French and the inch written. So French is the outer diameter, inch is the inner diameter. So 6 French catheter has a 6 French outer diameter. And if it says 038, 038 is the inch, which is the inner diameter, which means that a 038 inch guide wire can go inside this catheter, 038 or smaller. And 6 French means that a 6 French catheter is going to go inside a 6 French sheath. So for sheath, it's the inner diameter in French. For catheter, it's the outer diameter in French and inner diameter in inches. So next we have guiding catheters. These catheters usually they are not used for just taking a diagnostic angiogram. The difference is that for the same French, the same outer diameter, the inner diameter of these catheters is wider. So they are used for guiding other instruments through them. Themselves, they cannot hook different vessel origins. So they are put in place once the guide wire is already there and has already been taken there via a diagnostic catheter. Diagnostic catheter is taken out and guiding catheter is then put in place. And then through the guiding catheters, other instruments can be put. Also, they are more stiffer and they almost always have a braiding. Now, diagnostic catheters, the distal end can be tapered, but for guiding catheters, it is usually not tapered because they are more wide. So they also can have different angle tips, but mostly they are straight tip catheters. So after guiding catheters, we have micro catheters. Micro catheter is any catheter which is less than 1 millimeter or less than 3 French. So all catheters smaller than an outer diameter of 3 French are micro catheters. So these micro catheters are used when we have to cannulate very small and distal branches. And so as we go distally, the caliber of the catheters is going to decrease because the vasculature also decreases in caliber. The vessels become narrower as you go distally. So catheters also have to become narrower if they have to hook those vessels. And also we need longer catheters if we want to hook distal vessels. So microcatheters are usually longer than guiding or selective catheters, and they're also narrower or smaller in diameter. Now we know that guiding catheters and the diagnostic catheters always have to be pushed over a wire, otherwise they might cause vascular injury. Although the distal tip is atraumatic, they can still cause injury. However, microcatheters, most of them have to be passed over the wire, but we also have flow-guided microcatheters. In this case, they move ahead just with the blood flow and they need not be pushed over the wire. But then they are very, very fragile and care has to be taken to use them so that the tip is not destroyed. Flow-guided microcatheters are used for AVM embolizations intracranially. Because of the AVM, the vascular flow in the AVM is very high. So these flow-guided catheters anyways are going to go in the parent or the feeding vessel only, and they'll usually not go in the other vessels. And for all other purposes, we use over-the-wire microcatheters. So this is an example of a microcatheter. Again, the proximal end has a hub. The distal end might be shaped or might be straight, and we can even shape them with steam. And distal ends are usually soft and atraumatic, and proximal ends are stiffer. So now we have special catheters known as infusion catheters. They're usually used for catheter-directed thrombolysis when we place them inside a thrombotic segment and we infuse fibrinolytics or thrombolytics through them. So these infusion catheters are again end hole and side hole catheters. They have multiple side holes. They have a proximal and a distal marker. And then they have end holes and side holes within this segment. So length of this segment is variable and we can choose them depending on the length of the thrombotic segment we want to use them in. We can either do a pulse spray, that is we can connect them to a syringe and in pulses we can inject the thrombolytic agent, or we can even leave them in place and do a continuous infusion of the thrombolytic agent. So after catheters, we come to guide wires. Guide wires, again, they are used for guiding the catheters. I hope you can see this. So this is what a guide wire looks like. These are long and lengths may be variable. Again, they have a distal end and a proximal end. And if you're given a guide wire in your hand, how will you know that which is the distal end and which is the proximal end? You have to feel it. The proximal end is usually very stiff and distal end is floppy and atraumatic. The length of this distal floppy and atraumatic segment might be variable, but this has to be very floppy so that it does not cause any vascular injury. Guide wires directly go into the blood vessels, and they're used to sometimes they're used to hook the vessels, but mostly they're used to navigate once the vessel is already hooked. Sometimes guide wires might not be able to go inside the origin of the vessel. That's when just the catheter goes in. But once the origin is hooked, the catheters are always advanced over the guide wire. So first the guide wire goes in and then over it, the catheter or microcatheter goes in. Guide wires come in different lengths and in different calibers. So we have to know the length of the guide wire. Okay. So we have to know the length of the guide wire as well as the diameter of the guide wires. So the diameters of these guide wires is usually in inches and they can go into corresponding catheters. And the construct of a guide wire is it's not just a simple piece of metal. It has an inner stellate or an inner mandrel. and over this, a small wire is wound. So the material of this mandrel also varies, and this winding wire also varies. And then this entire thing is covered by a hydrophilic coating. So are the catheters, outer and inner surfaces, they're covered with the hydrophilic material, and also the guide wires. So once they are wet, they become very slippery. Towards the distal end, sorry, towards the distal end, the core or the mandrel is very thin, which makes it floppy and atraumatic. And proximally, this core or mandrel is thick. And this entire thing, they might be covered with the hydrophilic material or might not be, but usually they are. Then, based on the shape of their tip, they can either be straight tip, curved tip, or J tip wires. And then, also based on their stiffness, they can be either normal wires, they can be stiff wires, or extra stiff wires. Normal wire, which is most commonly used, is the Terumo hydrophilic guide wire, and this is used for navigating catheters through various arteries. But in some cases, if the vasculature is very tortuous and a catheter does not go over the floppy wire and it keeps falling down, that's when we use stiffer wires. So the use of stiffer wires is one, to introduce stiff devices like stents. Aortic stents are the stiffest devices, so they are used over extra stiff wires. And other stents like carotid stents or peripheral stents can be used over stiff wires like the Amplatz wire. So these stiff wires usually, although they have a distal atraumatic end, they are usually very traumatic, and they are put inside the catheter once the catheter is in place. The catheter is taken in place over a normal wire. Then when you want to introduce a stiff device, you remove the normal wire, put in the stiff wire, remove the catheter, and then put the stiff device. But stiff wires themselves are not navigated directly in the vessel, otherwise they're going to cause injury. Also, length of the wire varies. Normal length wires are usually 160 centimeter wires. But then we have exchange length wires, which are longer and are usually 260 to 300 centimeters. This is because if we have already reached a position and now we want to change one catheter with another. So if we have a small wire, we will not be able to exchange the catheter, because whenever we are working, we should always have one end of the wire in our hand. But if we are removing the catheter, then the wire will go in the catheter and it can be lost inside the body. So we use very long wires over which the catheter can be removed. So the length, if we want to exchange the catheters, the length of the wire should be more than double the length of catheter, so that some part of the wire is always in our hand. This is the Terumo wire, which is most commonly used. It's black in color. Usually a curved tip Terumo wire is used. This is the stiff Amplatz guide wire. The end may be straight or may be curved. Usually green colored wires are stiff. When you take them in your hand, you'll be able to come to know that they're very stiff and they keep opening, and Terumo is relatively soft. Then we have micro guide wires. Again, the principle of the wires is same, but they are smaller in size. The smallest micro guide wire which is available is 0.08 inch, which is used in very small intracranial catheters. Then next we have devices which are used for opening up the arteries. Once we have reached inside the arteries, we've taken a diagnostic run. Now we actually want to do the procedure. So this one procedure is that we are going to open up a blocked segment. So for that, the devices which we use, the most common is a balloon catheter. Balloons are usually mounted on the distal end of a catheter. That's why this catheter is known as a balloon catheter. So the use of this is either to open up a blocked vessel, as in angioplasty, or sometimes they are used in coiling of intracranial aneurysms when the neck of these aneurysms is very wide. So when balloons are used, they are placed across the neck. And when the coils are placed in the sac, during the placement of coils, the balloon is inflated so that the coil mass does not fall in the main artery. And once the coiling procedure is over, the balloons are deflated and taken out. However, if the neck is very, very wide, then even after deflating the balloon, the coils might fall down. That's when we do stent-assisted coiling. So these are the two main uses of balloons, and sometimes balloons are also used for clot retrieval. Like if we have a blocked intracranial sinus, we are going to go inside the sinus distal to the clot. Then we have retrieval balloons like Fogarty's balloon, which we are going to inflate and we are going to pull it back. So with the inflated balloon, these balloons are very soft. So when you pull it back, the entire clot mass is going to come back. So that is another use of balloons. So whenever we talk about balloon catheters, these are balloons which are attached to the distal end of the catheters. The balloons have a diameter and a length. And this is usually written on the hub part of the catheter. So if it's a 2 by 30 mm balloon, so the first figure, that is 2 mm, is going to be the diameter of the balloon. And 30 mm is going to be the length of the balloon when it's inflated. So these balloons, the size depends on the vessel which we are using. If you are using it intracranially, you would want a smaller caliber balloon. If you are using it in the, say, the common iliac vessel, you want an 8 or a 9 mm balloon. And if you're using in veins like SVC, then you want even larger balloons like 8, 10, or even 14 mm balloon. Diameter balloon is required. And then length also, they come up to 20, they come in very large sizes also. Usually for peripheral arterial disease, you want longer balloons. So diameter and length both is variable. So this is one thing. The other thing is that these balloons can either be a double lumen balloon or a single lumen balloon. This is example of a double lumen. How do you know that? If on the hub end you see two lumens, they are double lumen. One lumen which is continuous with the inflow. This is which is used to flush the catheter. So the lumen of the catheter and lumen of the balloon are not communicating with each other. Through this, we are going to flush the catheter and wire can be introduced. And through this, if we put saline or contrast, the balloon is going to get inflated. So this is the inflation port and this is the flushing port of the balloon catheter. Then we have single lumen balloons, which have only one lumen on its hub. And then these balloons are usually a monorail type of system. That is, when you say this port is used for inflation of the balloon, and the wire usually enters from the distal end, and there's a hole in the mid shaft of the catheter through which the wire comes out, as you can see here. So once the wire is in place, you are going to load this balloon over the wire. The wire will go here and the proximal end of the wire is going to come out from here. So these monorail balloons are also called rapid exchange balloons. And the advantage, as the name suggests, is it allows rapid exchange of devices. You don't even need an exchange length wire, even on a smaller length wire, because it's coming out from here. A normal length wire can be used to change this balloon with other devices. And whenever you want to inflate the balloon, it's done through the hub, where only one lumen is present. So this is another type of balloon. This is in the collapsed state, and this is after its inflation. And you can see there are some blades on the balloon. So this is a cutting type of balloon. Then balloons were divided based on the lumen, a double lumen or a single lumen. Then based on their stiffness, they can be either extra compliant, compliant, or stiff balloons. So extra compliant and compliant balloons are usually used in intracranial circulation. Suppose you want to do balloon-assisted coiling of an aneurysm. You don't want the balloon to be so stiff that it injures the artery. So you need a soft or a compliant or extra compliant balloon. But when you are opening up a blocked peripheral artery, say you're opening up the femoral artery or the iliac artery, you need a stiff balloon so that it can cut through or it can open up a very tight stenosis. So that's where stiff balloons are used. And sometimes the plaques are calcified plaques or very thick plaques. That's when you use cutting balloons, which in addition have cutting blades on their edges. And these are used to cut. They're usually 3 radially arranged cutting blades, and they're used to cut through the plaque and assist in angioplasty. So what this balloons also have, whenever you're inflating the balloon, all balloons come with a chart. So they have a nominal pressure and a burst pressure, and this is something which you have to know. Nominal pressure is the pressure which should be the pressure with which you should insert saline or contrast. Usually diluted contrast is used to inflate the balloons, and the pressure till which you can inject this contrast is the nominal pressure when the balloon reaches its desired diameter. If it's a 2 mm balloon and the nominal pressure is 8, so when the pressure reaches 8 atmosphere, this balloon will be dilated till 2 mm. If now it reaches 10 atmosphere, the balloon will be more than 2 mm in its diameter, say 2.1 or whatever, more than 2. Then they have a burst pressure, which is the maximum pressure which this balloon can hold. So if the pressure is more than the burst pressure, the balloon is going to burst. So never the pressure should increase the burst pressure of the balloon. And this is the balloon insufflation device. This is usually filled with diluted contrast and meniscus to meniscus without any air. It is attached to the hub of the balloon from where inflation is done. And then graded inflation of the balloon is done, and we stop when we reach the nominal pressure or slightly higher, but we never reach the burst pressure. So then if you have done an angioplasty and there's recoil and the vessel is still collapsing, so what do? You put in a stent. So stent are metallic tubes, and they're made of either stainless steel or nitinol or alloys. And the most common use of stent is to open up a blocked vessel after angioplasty if angioplasty is not enough. The other use, as we've already discussed, is to do a stent-assisted coiling in wide-necked aneurysms. So now, depending upon how they open up, they're either self-expandable stents or they are balloon expandable stents. So most of these stents, when they come, they are not like this. I'll show you how the stents which we receive. So this is how the stent comes in. It's inside a coil. The stents are in a collapsible state, and then they are attached to a delivery wire. So that's the delivery wire. The stents are attached to the delivery wire and in a collapsed state and placed inside a plastic tubing. So when you want to deploy a stent, the stent is collapsed inside this plastic tubing and the delivery wire is here and the stent and the wire are attached. Now, when I want to introduce this stent, this is the hub of the catheter. I'm going to put this stent, this plastic tube which contains the stent in the hub, hold it from here and push the delivery wire. Once it's in, I'll remove this plastic thing, and now the stent is inside my catheter in a collapsible state. Now, when I keep pushing the delivery wire, see what happens to the distal end. So this is the distal end. I hope you all can see. When I push it, the stent is coming out. This is the stent which is coming out, and it is attached to the delivery wire. And once this stent is in place, we are going to detach or deploy the stent. So some stents, when they come out, they take their original shape, and that is what is known as a self-expandable stent. So then they are self-expandable. Sometimes the stents do not expand on their own and they're mounted on balloons. So this is a balloon mountable stent, which is mounted on a balloon. It is placed across the plaque. The balloon is expanded. The stent gets expanded. Then we deflate the balloon and take it out, and the stent remains in place. So this is an example of a balloon mounted stent, which is mounted over the balloon. Again, a double lumen balloon, always in this case. And this is the balloon inflation port through which the balloon gets inflated. And this is a self-expandable stent which is deployed on a guide wire. So now if you look at the stent struts, this is one way of classifying the stents. So these stents are usually bare metal stents. They don't have any covering. The other way to classify stents is an open cell stent. As you can see, these various cells of the stent are not connected to each other. So this is an open cell design. And if these crisscross are connected to each other and all cells are separate, then it is a closed cell stent. So this is another way of classifying stents. Then what we discussed were bare metal stents. Now we have something known as stent grafts, in which these stents are covered by a PTFE coating or a PTFE material. So now these are no longer stents, but these are like cylinders or tubes which are impervious or imporous. So what is the use of these stent grafts? They are usually used when the vessel is destroyed. So if there's a pseudoaneurysm of the vessel, which is usually due to injury to the vessel wall, we have to make a new passage for flow of blood through this vessel. That is when we put in a stent graft. It should have a proximal and a landing zone, which is normal, which is the normal part of the vessel, where this stent can be, this stent graft can be anchored. And so a new passage for blood flow has been formed and blood is no longer going in the pseudoaneurysm. So these are stent grafts. Now we have some special type of stents known as flow diverters. These are used intracranially for large wide-necked aneurysms. And these are somewhere in between stents and stent grafts. One problem with stent graft is that we are very, very stiff. And if you place, if say, suppose there's a branch arising from here, then that is also going to get closed. And if this is tortuous, these grafts don't bend very easily. So they'll not oppose well to the vessel wall and there'll be vessel leak. So this is the problem of stent grafts, that they can be deployed in a relatively straight segment, which does not have any side branches. So these flow diverters are somewhere between stents and stent grafts. So they don't block 100% of blood flow as stent grafts, but they block at least 70% of side flow. So the flow into the aneurysm will not be absolutely absent once you deploy them, but there'll be stasis. The flow will be slower, and with time, this is the aneurysm is going to thrombose and collapse. So that is the idea behind deploying a flow diverter, and they're used to treat intracranial wide-necked aneurysms or blister aneurysms. Then we have something known as stent retrievers or stent reavers. As the name suggests, they are retrievable stents. So once they come out, they're still attached to the wire. They're left in place for some time and then retrieved back. So what is the use of doing this? The indication of these stent retrievers is in mechanical thrombectomy in cases of stroke. So whenever there is blockage of an intracranial vessel due to a clot, this is the treatment of choice, this or aspiration, and this combined with aspiration. These stents, the catheter first crosses the clot, and this stent is deployed across the clot and left in place for 3 to 5 minutes. So what happens when this is deployed? We expect that the clot is going to get engaged within these struts or cells of this stent. We give it some time, we give the clot time to get engaged, and then after some time, this is partially sheathed and the entire thing is pulled back, and usually the clot entangled in this stent retriever comes out. So these again come in various sizes. The size, the diameter and length may be variable, and for all types of stent, we usually have a compatible delivery microcatheter. So if it's a larger stent, then the catheter through which this stent can be deployed should have a larger inner lumen. And if it's a smaller stent, it can be deployed through a smaller catheter. So always compatible delivery microcatheters are required with stents. So once we've discussed about materials which are opening up blocked vessels, we'll be discussing about materials which are now sealing leaked vessels. These are embolizing devices or sealants. So they are like materials or tape which is going to block any excessive or extra leakage in the vessels. So then these, depending on their composition, they can be either particulate, liquid, or solid embolizing agents. And depending on their action, they can be either temporary or permanent. So this is something that you all have to be very thorough with, because this is something that is invariably always asked in a IR table viva. So the first and foremost is gel foam. Gel foam usually comes as sheet or it comes in pre-cut pledgets. What we get is this, and this is a temporary embolizing agent. You have to remember that there's only one agent which is temporary. The other one is autologous blood clot, which you're not going to be shown, but you have to know. But gel foam, out of all the materials that will be shown, gel foam is the only one that is temporary. And the effect lasts for 5 to 7 days, and in about 6 weeks, it's completely absorbed within the body. So it usually comes as sheets. And how do you use them? You take a blade, and with the help of the blade, it is scraped and small particles are formed. Now, these particles are then mixed with saline and contrast, and a slurry is formed, and this is injected for embolization. The use of these particulate agents and especially gel foam is in preoperative embolization of tumor vessels. This we can afford to have a temporary agent because anyways the patient is going to get operated in a day or two. So then temporary agents can be used. And the other indication of using gel foam or a temporary agent is when the patient has had trauma and he is bleeding, but there's no aneurysm or no site where we say a visceral bleed, and there's no site of visceral bleed. So how do we stop bleeding? We empirically inject gel foam in the visceral vessels, and we expect that it will cause some embolization of the distal vessels and will decrease the mean arterial pressure. So the bleeding is going to decrease, but we don't want the visceral vessels to be closed forever. That's why we use a temporary embolizing agent. So these two indications you have to remember. And the third indication for gel foam is usually when we're doing biopsies and the patient has coagulopathy or very vascular tumors. That's when we are taking the needle out after biopsy, we inject a plug of gel foam. It's called gel foam plug biopsy to prevent bleeding. So one disadvantage is that because we are doing it manually, all the particles are of different sizes and they usually clump together. So when they clump, they can either block the catheter or they can block a main feeding vessel and they may not percolate distally. So next embolizing agents are PVA particles. These are made of polyvinyl alcohol and they come as small round microspheres. They come in different sizes. Again, the main use is they are the particles which are used in most of the embolization procedures like uterine artery embolization, bronchial artery embolization, or they're used for tumor vessel embolization. When they're used for tumor embolization, we have to remember of tumor embolization is embolization of the arterioles. So appropriate sized particles and catheters have to be selected. If you select very large particles, then what's going to happen is that you're going to block the feeding artery itself. So then tumor may recruit supply from other arteries and it might still have vascular supply. And now if you use very small size particles, they're going to cross the arterioles and reach the capillaries. So one disadvantage is that there might be intratumoral shunts. So through the shunts, these small particles can go and cause distal non-target embolization. And also very small particles can also go in the arteries which are supplying the skin. So there'll be skin necrosis or perineural vessels. So there'll be nerve involvement or involvement of the vasa vasorum. So appropriate size particles always have to be used. Most commonly used particles for uterine artery, bronchial artery, or tumoral embolization is 300 to 500 microns. And these again are radio opaque. They are not radio opaque. They are mixed with saline and contrast to form a slurry, and then they are injected inside the catheters. Another thing to remember is that these particulate agents, be it PVA particles, be it gel foam, they're not used in high flow vascular malformations because in high flow they're not going to cause embolization of the malformation, but they're going to go to the venous side because of the very high flow, and then they're going to cause non-target embolization. So selecting the size is important, and the size varies from 500 to 2000 microns. Most commonly used are these 300 to 500 microns. Then after particulate agents, we have liquid embolic agents. The most commonly used one is glue. Glue is usually cyanoacrylate. The most commonly used one is N-butyl cyanoacrylate, although histoacrylate glue can also be used. So glue is a very potent and a very strong embolizing agent. And mechanism of action is that whenever it comes in contact with an ionic substance, it is going to polymerize or solidify. So blood as well as saline are both ionic. So what do we do? That the main use of this, because of this property, is in embolization of high flow vascular malformations intracranially or in the peripheral circulation, and also in case of visceral pseudoaneurysms. So when it solidifies, when it comes in contact with blood, when it reaches the abnormal AVM, it is going to solidify inside the AVM vessel and form a cast. So AVM will be excluded from circulation. But if we use saline inside the catheter, it is going to coagulate within the catheter only. So before injecting glue, the catheters, the hub of the catheter, everything is flushed with dextrose so that the glue doesn't polymerize. After flushing with dextrose, we inject glue, and we have to make sure that there's no reflux of blood in the catheter. Otherwise, catheter is going to get stuck at the site of AVM and it will be difficult to pull it out. Also, there's something known as lipiodol, which is used in conjunction with glue. So what is this lipiodol? Lipiodol is ethyl ester of poppy. It is very viscous and this brownish or light yellowish in color. Use of lipiodol is twofold. One is that glue by itself is not radiopaque. So it provides opacity to glue and you can see where the glue is going. And the other thing is that we don't use 100% glue because 100% glue is going to polymerize as soon as it comes in contact with blood. Lipiodol usually is used to alter the concentration of glue. And why do we need different concentration? This is an example. Say this is the AVM which I want to embolize. This is the vascular malformation. So now I can have two scenarios. One is that I want to avoid embolizing these vessels and I just want to embolize these. If my catheter is here, then I'm not going to embolize because there'll be non-target embolization. Now, if I'm able to negotiate my catheter only till here and it's not going here, so what I want is that glue to polymerize after some time. I want it to travel all the way here and then polymerize. So I'm going to use a diluted glue, more of lipiodol, less of glue, so that it polymerizes after it reaches here to buy some time. But if my catheter is right here, right at where the abnormality is, I am going to take more concentrated glue. That is more of glue, less of lipiodol, so that it polymerizes soon and doesn't take more time. So usually the concentrations which are used in endovascular procedures are 30 to 50%. Sometimes even 60, 70% is used. Very rarely when we are doing percutaneous injections through a steel needle, we may use 100% glue. But then in 100% glue, there's no lipiodol. So how is glue opacified then? We mix it with tantalum powder, which gives it opacity. It's not mixed with lipiodol when we're using 100% glue. And also, whenever we are using glue, we usually use glass syringes because plastic syringes usually melt. Then the other liquid embolic agent which we have are EVOH based agents or ethylene vinyl alcohol based agents like onyx and squid. So they usually come in small bottles, 1.5 or 3 ml bottles, and are black in color. They're black because they have tantalum powder. So these agents, onyx or squid, are usually composed of ethylene vinyl alcohol based copolymers with tantalum, which is in suspension. So always before procedure, these have to be shaken so that the suspension is uniform and tantalum is not settling down. So whenever we are starting the procedure, we put this on a shaker and at least 20 to 25 minutes, the vortex shaker is on and it keeps on shaking. And only after that we use it. And the diluent or the diluting agent which is used is DMSO. So DMSO is dimethyl sulfoxide, but we have to remember is that we never mix the two. Whenever the catheter is in place and now we have to inject this embolic agent, we first inject DMSO at a slow rate because it is vasculotoxic. And once DMSO is injected, then we inject onyx or squid after that. And always whenever we are using this, all catheters are not compatible with DMSO. So we have to make sure that we are using a DMSO compatible catheter. The difference between the two is that this is glue, which when comes in blood, it solidifies almost instantaneously and it causes a lot of inflammatory reaction. However, onyx or squid on the other hand is more rubbery like. So it takes time to solidify and it solidifies from outside to inside. So we maintain a small forward pressure all the time so that it can be injected over prolonged periods of times, from minutes to even 1 to 2 hours, we can keep injecting it. If we don't stop, the central portion is not going to solidify. So we can stop for say 2 minutes, then inject some, then stop. So periphery solidifies first, and it solidifies in a rubbery material, rubbery like fashion. So the uses of onyx or squid is intracranial AVMs. When they're large AVMs, we want good percolation. That's when we use these. And also for very vascular tumors like paragangliomas or say carotid body tumors, percutaneous embolization by using squid or onyx can also be done. Next, we have solid embolizing materials like coils. So coils usually are made of platinum or steel, and then they are mounted over wires through which they are pushed into the catheters. So the coils, they can be classified into various types. Depending upon their shape, they can either be helical or 3D coils. So helical coils have this helical structure, and 3D coils has this 3D structure. So whenever we talk about size of the coil, we talk about the diameter of the loop of the coil and the length of the wire. So this structure which we are seeing of the coil is a tertiary structure of the coil, and this diameter is usually the diameter of the coil. So this, if we selection of this diameter depends in cases of aneurysm, the size of the aneurysm sac, and if we want to do a parent vessel occlusion or occlude a main vessel, it depends on the diameter of the vessel. But now, so this, what we see is the tertiary configuration of the coil. If we hold this and pull, it will turn into a wire. So that this wire is what it is going to turn into. So the length of this wire is actually the length of the coil. It is not the length of the coil when it's coiled on itself, but it's the length when it is stretched into this secondary structure. So this diameter of this secondary structure can be either 018 or 035, and this directs the size of the catheter through which this coil can pass. So if it's an 018 coil, then it will pass through a smaller catheter. If it's a 035 coil, it will pass through a larger catheter. And actually, the coil also has a primary configuration, which is not taken into account in measurements, but it decides the stiffness of the coil. If you pull this wire further, this secondary structure, it is going to turn into a very, very thin core wire. So, but what you have to know is this diameter of the tertiary structure and this diameter of the secondary structure, which decides the coil size. So when I say I'm using a 2x3 coil, so 2x3 coil means usually we talk like this, like 2x3 or 4x3 coils or 4x5 coils. So the first number, like in a 2x3 coil, 2 is 2 millimeters, which is the diameter of the coil, and 3 is 3 centimeters, which is the length of the coil. So this depends on the size of the aneurysm which we are using the coil to, which we are using the coil for. Then one is based on the shape, and second is based on the modes of detachment. One is the free coil. So when the coils are also loaded like stents, they are stretched, loaded in a plastic tubing and attached to a delivery wire. Sometimes they're not attached to a delivery wire. They're just put inside a tubing. So then they are pushed inside the delivery catheter and pushed forward with the help of a wire or even saline. And then they come out through the distal end of the catheter. They're going to assume their coil shape and block wherever that distal tip of the catheter is. So they're just going to come out and get deployed. We have no control over their deployment. And then we have detachable coils, which have a detachable wire attached to one end. And so once they are out, if we feel that the position of the coil is not right, we can retract them and then deploy them again. So we have a controlled deployment of these coils. So free and detachable. And detachable mechanisms can also be very different. So then we have another embolizing agent, which are detachable balloons. These are no longer used. They were used earlier for embolization of caroticocavernous fistulae. But now we usually use coils. So they are catheters they are balloons which are mounted on one end of a wire or a catheter, and once in place, they are detached and left in place. The problem is that with time they deflate. So whereas the coil does not, so coils are now preferred. When we were talking about coils, what are the uses of coils? Uses are for coiling of aneurysms. You have to remember that coils are placed inside the sac of a true aneurysm and not a pseudo aneurysm. This is a mistake which most of the people make in their vivas. A pseudo aneurysm has no wall. So if you put in a coil inside a pseudo aneurysm, it is going to rupture. So for pseudo aneurysms, you either put a stent graft in the vessel from which the pseudo aneurysm is arising if you cannot sacrifice that vessel. Otherwise, if it's in a visceral location, then what you do is that you are going to coil the neck of the aneurysm, both proximal and distal. You're going to go past the aneurysm in the normal vessel, start coiling the artery from distal to the neck of the aneurysm, across the neck and proximal, so as to trap both the distal and proximal ends of the vessel. If you just coil it at the proximal end, it is going to recruit some other supply and get filled from the distal end. So whenever there are organs like liver or a GDA pseudoaneurysm, gastroduodenal artery pseudoaneurysm, if you just coil the proximal aspect, it's not enough. You have to coil it in a trapdoor manner. However, if there's a pseudoaneurysm in a renal artery, the difference here is that renal arteries are end arteries. So in this case, if you occlude the proximal main artery, it is because it's an end artery, the pseudoaneurysm is not going to get filled distally. So in these cases, proximal occlusion is enough. And sometimes if you're stuck in a situation, if it's a GD aneurysm and you're not able to navigate beyond the neck of the aneurysm, then do you just do a proximal coiling and come out? The answer is no. In these cases, wherever you are from that location, you can inject a liquid embolic agent like glue, and then you make sure that the glue percolates slightly distal to the aneurysm neck, so that both the proximal and distal aspect of the aneurysm are closed. So after embolizing agents, we'll be discussing sclerosing agents, which are used for slow flow vascular malformation and varicose veins. The most common one used is STS or sodium tetradecyl sulfate. And the mechanism of action is that in these cases, they're usually superficial. And what we do is that percutaneously, we puncture these vascular malformations. We take a nidogram and see that we are inside. Then we inject the sclerosant. So this sclerosant is going to cause endothelial injury and inflammation. So this is after inflammation, the entire thing is going to sclerose, and thrombosis of the blood in the vascular malformation will take place, which will eventually sclerose and decrease in size later. So the most common one used is STS, and it is what we do is foam sclerotherapy, wherein STS is converted into foam. So how do you use it? You mix it with equal parts air and half the amount contrast. That is 2 ml STS, 2 ml air, and 1 ml of contrast. And then you make foam by mixing it in two syringes attached to a three-way cannula. So you mix them and then you inject them. So this foam, what does the foam do? It increases the surface area of the sclerosant, increases the contact with the vessel wall, and it increases its action. So STS is the most commonly used, and it's used in slow flow venous malformations. Like in this case, this MR shows a venous malformation here. It is seen on ultrasound. Under ultrasound guidance, this is punctured with a needle. And then first a contrast nidogram is taken, and then STS is inserted. Then another agent which we use is bleomycin, which is usually used in large unilocular cystic lymphatic malformations. But bleomycin, you have to remember, is a cytotoxic agent. So the dosage has to be calculated and a tab has to be kept. It should never increase the maximum permissible dose. The other agent which is used is polydocanol. Polydocanol, the mechanism of action is similar to STS, but it is less inflammatory. So it is used in situations where we don't want a lot of inflammation, like if it's an intraorbital AVM or intralaryngeal AVM, where inflammation in the eye might injure the optic nerve, or in the larynx breathing difficulties. So we use polidocanol, but we have to know that the effect is also going to be less because it's less inflammatory. Then other devices which are used in vascular interventions are distal embolic protection device. This is usually used in carotid stenting, wherein when we cross the plaque, there are multiple fragments of the plaque which are disrupted and they can go distally. So to prevent them from going into the distal circulation and causing stroke, we have a filter or a protection device known as a carotid filter, which is placed beyond the level of obstruction. And it's an umbrella-like device which is going to catch all the plaque fragments which are disrupted. So this is a distal embolic protection device. We also have proximal embolic protection devices if you're not able to navigate it beyond the obstruction. So therein we apply a negative suction pressure proximally so that all the clots or the fragmented plaque come proximally. But this is usually placed in a straight segment of distal cervical ICA. Then we have retrieval devices which are called snares, which can be loop-like or basket-like. Again, they are in collapsible forms inside the catheter, and when the wire is pushed, they come out and attain this configuration. So how they are used is that if there's a broken guide wire or a broken catheter which we need to catch, we usually try and engage it within the loop of the snare. Then we close this catheter so that it's stuck between the catheter and the loop, and we pull the entire system out. So this is how a snare looks like in its open form. This is how it was used to retract this broken fragment of a catheter. So then we have other devices like long sheath. The ones which we saw were short sheaths or femoral access sheaths. We can have sheaths in various diameters and sizes. This is something which is a long sheath, similar to an access sheath, but much longer in size, and diameters can be variable. This is a 9 French long sheath, so we have black color at the hub. And this is a 6 French long sheath. So if you can see, the color at the hub here is green. So why are they used? They are used when we are, they are used for additional support. In place of guide wires, these long sheets can be used, or guide wires can be, guiding catheters can be passed inside these long sheets, or they can be used in place of guiding catheters. This is a crossover long sheet. When through one iliac vessel, we go into the other. So this bend, it sits on the aortic bifurcation. This is a straight long sheath and usually used in carotid artery stenting or distal intracranial procedures. So sheaths can also have different lengths, different diameters, and different distal shapes. So then we have something known as a micropuncher set. This is used in, we usually use a single 18-gauge needle, but when we are puncturing the vessel of a child, which is very small, or we are puncturing a vein, we might cause injury or spasm by a big puncture needle. So these are tiny or small puncture needles. Usually they are 21 gauge. They come with a thin 18018 guide wire, which goes into this micropuncture needle. Then we have this sheath and dilator assembly. The inner one is 3 French and the outer one may be 4 French or 5 French. So once this needle goes in, we put in this thin guide wire, take the needle out. Then this sheath and dilator assembly goes in over the wire. The dilator and this wire comes out and only the sheath remains in. So now this 4 French sheath is going to accommodate a normal 035 guide wire. So through this, the small J-tip 03 guide wire is introduced. Then this sheath is taken out, and then the normal femoral access sheath can be introduced. So it is a way of continuously dilating the vessel and then introducing the larger bore devices rather than introducing them at one go. Then we have IVC filters, which are used in cases of deep vein thrombosis when the patient has a contraindication to anticoagulation therapy. That is the only absolute indication of putting these IVC filters. And the purpose is to prevent pulmonary thromboembolism. So these filters are usually shaped like a cone or triangular in shape. They are either closed cell or open cell. They have a neck or a stem and a hook. And then they have these struts, and they can be retrievable or they can be permanent and they cannot be pulled back. They're usually deployed in the infrarenal segment of IVC, but if cannot be deployed there, they can even be deployed in the suprarenal segment. And they can be introduced either through the femoral route, through the femoral vein, or through the IJV. So this is how a deployed filter inside the body looks like. It has a hook here. And for retrievable filters, then they can be retrieved with the help of this hook. In a collapsible manner, again, they are present inside, they're attached to a wire and they are present inside hollow tubes. And when pushed out of the catheter, they assume this open configuration. They can have many complications which you should be aware of. One is that if the sizing is not proper, if you use a smaller filter, they can migrate and go in the heart or the pulmonary circulation. Then with time, even retrievable filters, they can get stuck to the site where they are. They can perforate the IVC. Their barbs or struts can perforate the IVC. They can migrate outside, or they can be fracture of the filter parts over time, which can then migrate distally. So various complications can occur, and sometimes when they're left for a very long time, they themselves can become thrombogenic and cause IVC thrombosis at the site of placement. Then other accessory equipments are syringes. So the syringes which are used for vascular procedures are usually Luer-Lock syringes. Luer-Lock syringes look like this. So they have a luer or a screw at their distal end. So these are important because they provide tight connection to the catheter, and there's no spillage of contrast or saline, whatever you are injecting. So there's no injury to the operator also, less spillage also, and more controlled injection. So always for vascular procedures, we use Luer-Lock syringes. The most commonly used syringe is a 10 cc Luer-Lock syringe, and plastic syringes are used. However, these glass syringes can be used when we are using liquid embolic agents like glue and DMSO. Then there is something which is known as a vacuum or a vacuum lock syringe. It is a 50 cc syringe and it comes with a lock. So this can be shown in the Viva, and the use is in mechanical thrombectomy for clot aspiration. They can be used in place of an aspiration pump. When you're using your aspiration catheter and the aspiration catheter is sitting at the mouth of the clot, then you can either connect the hub of the catheter to an aspiration pump. And if the aspiration pump is not available, you can connect it to a vac-lock syringe and lock it so that this aspiration effect can be there for around 1 to 1.5 minutes. And then you can pull the entire thing out and pull out the clot. So the other thing which is commonly used is this. This is a torque device. This is attached to the proximal end of the wire, which is in our hands. Sometimes the thin wires, like the micro wires, it's very difficult to rotate them. So this torque device is attached. It can be easily held in the hands and it can be easily rotated. So this is something which is very commonly used, and you should know it's very small. Then this is something known as a scalp vein or a butterfly cannula. This is used in sclerotherapies. It has a small needle and a plastic tubing attached to it, and through this the sclerosant is injected. Okay, then coming to non-vascular procedures, the most commonly performed procedure is biopsy, and these biopsy guns are the most commonly asked instruments in the table-viva. So the biopsy gun is biopsy needle attached to a handle. They are used for biopsy of superficial or deep structures. So for biopsy guns, you have to know the gauge of the needle and the length of the needle. They can be either automatic or semi-automatic. So the needles, what does a biopsy needle usually consist of? It's a two-part needle. The inner stylet This is the inner stylet. It has a notch or a tray. And this is the place where the biopsy specimen is collected, in the notch or tray of the inner stylet. And it has an outer cutting shaft. So once it goes in, this is the outer cutting shaft which comes out and cuts the biopsy sample so that it is collected in the tray. So this is an automatic needle. What happens is that once you advance the needle and you reach your site of interest, the inner tray, the inner stylet, and the outer cutting shaft, they get deployed almost instantaneously. Like this, both of them come together. So one is that you have to be proximal to the site of biopsy which you want. You just have to be at the tip because it is going to go forward and you really cannot control where it is going to go. And the other thing is that if you're very close to a very vital organ, then you should not use this. You should use a semi-automated system. So this is a semi-automated system. You pull it back to load it. So once you are inside, you have reached your lesion, say it is here, you push it and the stillet comes out and the cutting shaft is still not out. So you exactly know where your biopsy sample is going to be taken from. Then you fire when you want to, when you are ready, you fire, and that is when the outer cutting shaft comes and takes the biopsy sample. So whenever you are in a location where you need very precise sampling, you always should use a semi-automatic needle. And also these needles, they vary in length, they vary in the size of throw or the biopsy sample which can be taken. Usually a semi-automatic is a 18 gauge needle. The length of throw is either 11 mm or 22 mm. An automatic needle, usually it is a 16 gauge needle, and the length of throw again can be 11 mm or 22 mm. And this is a introducer needle. Usually when we are using semi-automatic needles, we use this needle which has a stillet and is usually 16 gauge. We take it at the site which we want, and then we take out the stillet and then we thread this biopsy gun through it. So the advantage is that every time we don't have to re-enter the lesion and focus the lesion again and again. Once it is done, we can just we can take this out, take our sample, and when we need a second pass, we can just change the direction of this introducer needle, which is already inside the lesion through which the biopsy is required. So this is something which all of you should be very clear with, the use of automated and semi-automated biopsy guns. So also this is something which we left. This is a pressure bag. It consists of an insufflator cuff and a saline bag, which is in which the saline is encased in a very thick plastic bag. It's not the usual saline. And why do we want high pressure salines? This is used to flush our catheters in cases we are having long continuous procedures. So we use a pressure bag for continuous flushing of our equipment. And because we are inside the artery, we have to overcome the arterial pressure while pushing in the saline. If you use a normal saline, then blood is going to come back in the BT set. But if you use high pressure saline, only then will the saline go in. So that's why we have these high pressure bags. So then also we have something known as vascular closure devices. Usually when the procedure is over, we take out all the instruments and then we take out the vascular sheath. Now we've created a hole in the vessel wall and we want to seal that hole. So that is usually done by manual compression. But sometimes we've used a very wide, a very big size sheath, like a 9 or 8 or 9 French sheath, or the patient is on anticoagulations, as in when you're putting in a stent, the patient is put on anticoagulations. So you know that he's going to bleed a lot, and manual compression either will take a very long time or might not be sufficient. So that's when we use these vascular closure devices. There are many available in the market. The two most commonly used ones are either a collagen plug-based device as this one, which is known as the angioseal. So this has a foot plate and a collagen plug which seals the hole in the artery. Or it could be a suture-mediated device like this, known as the ProGlide, which has a device and a knot pusher. So it is actually stitching the vessel around this, and the suture eventually gets absorbed in around 1 to 3 months. So you make a knot and you stitch the arteriotomy site. So vascular closure device, either collagen mediated or suture mediated. So biopsy guns we've already seen. So then some accessory equipments which you might or might not be shown. One is the TJLB or transjugular liver biopsy set. It usually comes in a set known as the LAP 100 set. So transjugular liver biopsy, as the name suggests, is done through the transjugular route. So once a jugular puncture is made, then a guide wire is put in, and this set might or might not have a catheter. And with the catheter and guide wire assembly, we usually reach the right hepatic vein, which is the most common site of taking a jugular biopsy. So once we are in place, the guide wire remains and this catheter comes out. Then we have this introducer with a dilator. So this assembly is put over the guide wire and taken inside the right hepatic vein. Then we have this long biopsy gun, which is a semi-automated long biopsy gun, which comes in this set. So then once this is in place, the dilator is taken out, and this biopsy needle is then sheathed inside a catheter, this long straight catheter. This is put inside this catheter, and this assembly is taken inside this sheath into the right hepatic vein. Once the wall, we position it against the wall of the right hepatic vein, then we advance first the inner stellate, and then we take a shoot, and the biopsy is taken. The sheath remains inside the catheter, and the biopsy, this long biopsy gun comes out. The sample is taken out, and again another shoot can be taken. So this is again, these are the steps wherein first with the catheter, we are inside the right hepatic vein, check angiogram taken to confirm the position. And then the sheath is taken here over the wire, and then through this, the biopsy is taken. So then another procedure which is done through the jugular route is TIPS, or the transjugular intrahepatic portosystemic shunt. This also, this TIPS comes in as a set, most known as a Roche Yoshida set. So this again, the steps are the same. You might or might not be shown this in the Viva, but you should be aware of this. So again, you take a jugular puncture, take your needle and guiding catheter into the right hepatic vein. Now, once you are inside the right hepatic vein, you take out the catheter, the guide wire remains, and this guiding sheath with the introducer is taken in. The introducer and wire are taken out, and we are only now left with this guiding sheath inside the right hepatic vein. So once inside, we take this catheter and the stiffening cannula. This stiffening cannula is put inside the catheter, and this assembly is introduced into the sheath, and then this is held against the wall of the right hepatic vein and is directed inferiorly and anteriorly towards the portal vein. So this stiffening cannula helps us to direct our catheter and the sheath towards the right hepatic vein and point it towards the portal vein. Once this is in place, we take this trocar stellate and put it inside this catheter outside. Now this trocar and catheter assembly is then taken and it is put inside this catheter, and then the trocar is advanced and it is taken inside the portal vein. Once inside the portal vein, you advance your catheter over the trocar and take out the trocar. So now you give an injection and confirm that you are within the portal vein. Once you reach the portal vein, over all the system that is there, you're going to push in your sheath, and the sheath is now across the right hepatic vein, across the created tract into the portal vein. Once you've reached there, you can now dilate this tract with balloon and put in a covered stent. So this is how the procedure is inside the right hepatic vein. Then you've created a tract, reached here. With a measuring wire, you can also measure the tract so that you know which size balloon and how long a stent you'll need. And once inside, you can deploy this stent. It's a covered stent. This covered portion is usually in the tract that you have created, and this open portion is in the hepatic vein or the portal vein. So this covered portion covers the tract which is there intrahepatically between the hepatic vein and the portal vein. You might or might not be shown this in the Viva. Sometimes it can come as a short IR case, but you should be aware of what is done. Then there are other devices which might or might not be shown, such as this atherectomy device. We've seen stent retrievers which are used to remove clots. And then this was a device which was used earlier, not very commonly used. But how it is used is that it has a nose cone and it has this cutting blade. So once we have a very tight plaque, it is used to shave the plaque off. So it is taken inside the plaque over the guide wire. You put the entire device in. So this device goes in. Then once here you switch it on and this starts rotating. It's like a cutting blade and it is shaving off the plaque. You pull it back and this plaque gets shaved off. So you're creating one tunnel within the plaque wherein the plaque is shaved off. So once you are here, then you rotate it a bit, again take it, then rotate it, again take it. And so in a coaxial manner, you will be able to take out the entire plaque. So this is post procedure. These images are taken from the net. It's very rarely used now, but this is how it can shave off the entire plaque. So that is all. And if there are any queries, I'll be happy to take.